Hello, everybody. Can you hear me?
Hello. Yes, sir.
Okay. This meeting will be recorded. Actually, I will lock the meeting. No one will be able to join the meeting anymore. I think there is some sort of reluctance to attend the lectures, and I don't know what's the problem. But we have to go on, okay? Okay. Do you have any questions before we start the lecture?
Sir.
Dr. Sai, do you have any questions?
No, sir.
Okay. Okay. Today's lecture will talk about the distribution of ventilation and perfusion throughout the lung. In the last lecture, we said that the intrapleural pressure is at end of normal expiration is negative, zero, or positive. Can you remember? The intrapleural pressure at rest.
Negative pressure.
It is negative. Okay. So it is negative. And this negativity, we said this negativity is not uniform. It is about at rest in normal conditions, minus 10 centimeter H2O at the apex of the lung and minus 2.5 centimeter H2O around the base of the lung. Okay? This pressure, why the pressure is more negative around the apex of the lung? Because the pleura is formed of two layers, which is the visceral layer, which is adherent to the lung, and the parietal pleura, which is adherent to the chest wall. So the weight of the lung tracts or pulls on the visceral pleura downwards away from the parietal pleura, making the intrapleural pressure more negative around the apical alveoli. This negative pressure is reflected on the alveoli. And as you know, the lung is connected to the airways, and the airways is connected to the atmosphere, which is considered to be zero. Okay? Do you know the difference between gauge pressure and absolute pressure? Do you know the difference between gauge pressure and absolute pressure, and what type of pressure we use during talking about the airway pressure, intrapleural pressure, and so on? Do you know the difference?
I am not sure, sir.
Okay. Dr. Batul, is this right? Dr. Batul, are you the other person, or you?
No, I don't have it.
You don't know. Okay.
Mm.
Absolute pressure is the total pressure applied to the airway, okay? including the atmospheric pressure, which is about 670 and 60 millimeters mercury. Okay, so I can consider the atmospheric pressure to be 760. Okay, and the airway pressure can be added or subtracted from this pressure. Okay, this is called the absolute pressure. But if we consider the atmospheric pressure to be zero, this is called the gauge pressure, and this is applied to the cylinders in physics when we will talk about the cylinders we use during anesthesia. The monitor or the gauge shows the pressure inside the cylinder, okay? And this is called gauge pressure. It does not consider the atmospheric pressure. It considers it as zero, okay? If we added the atmospheric pressure to the pressure inside the cylinder, this is called the absolute pressure. Did you get this point, Dr. Sai and Batul?
Yes, sir.
Batul, is this clear for you?
Yes, yes.
Okay, so Dr. Batul, do you speak Arabic?
No.
Okay. Um, so the negative pressure around the apical alveoli is reflected on the alveoli, the apical alveoli, which is connected to the atmosphere. So there is a gradient between the atmospheric pressure, which is considered to be zero, and the minus 10 centimeter H2O, which is now around the alveoli. So the air will enter these alveoli or remain inside these alveoli at end of normal expiration. Okay, so the pressure which is minus 10 will make the apical alveoli at end of normal expiration has high resting volume. If we convert this to the basal alveoli, the pressure around the basal alveoli is minus 2.5. So definitely the resting volume of the basal alveoli will be lower than the apical alveoli. So the basal alveoli will have low resting volume. Is this clear?
Yes.
Yes.
So when we start to breathe, what happens? We contract the inspiratory muscles. So the intrapleural pressure becomes more negative. Okay, so this drags air from the atmosphere. But this air now is between two ways. One way is empty alveoli, which can accommodate a volume of gas, and apical alveoli, which are full of gases and is about to reach its elastic limit. What do you think? The inspiratory gases will prefer to go towards the base of the lung or the apex of the lung?
Base of the lung.
The base?
Yeah.
Okay. Right, Dr. Sai? As the basal lung region, the basal lung has the alveoli of the basal lung region has a low resting volume, so it can accommodate the inspiratory gases. So although it has, or not although, because it has low resting volume, they have, okay, high changing volume. And in contrast, for the apical alveoli, which have high resting volume, they have low changing volume. So if we now interpret the distribution of ventilation throughout the lung, it is evident that ventilation is more at the base of the lung and decreases gradually towards the apex of the lung. Is this clear for you?
Yes, doctor.
So the basal lung regions ventilate better than the apical lung regions. Okay? And this is, if we look at this curve, Dr. Sai and Batul, the y-axis shows flow and VQ ratio or ventilation perfusion ratio. The x-axis shows the region of the lung. Either it is the bottom or the top. If we look at the ventilation at the base of the lung is high and decreases gradually towards the apex of the lung. Okay? Now let's talk about the distribution of perfusion. The same as for ventilation. Okay? This is the lung. Okay? And this is the pulmonary artery. This is the pulmonary artery. And this is the column of blood. And this patient is upright. If we said, Dr. Sai and Batul, okay, that the pulmonary circulation is a low pressure circulation, about, we can say that the systolic pressure is around 20 over 8 millimeters mercury in comparison to the systemic circulation, which is about 120 over 80. Okay? So for this patient who is upright, physically, the pressure at the apex and the pressure at the base, which is higher? Which is higher, Dr. Sai and Dr. Batul? What do you think? Which is higher? You can say I don't know, but please respond to me because I sometimes I think that the connection is abnormal or unstable.
I think the base of the
At the
lung
base, Dr. Batul, at the base, the pressure is higher or lower?
higher.
Is higher. Why it is higher, Dr. Batul? Due to the effect of Dr. Sai, the pressure at the base of the lung will be higher due to the effect of,
Uh,
say anything. It will be right. I think you will answer it right. This is a bright person. The pressure here will be higher due to the effect of,
uh,
it's right. Say it, please. It starts with G.
gravitational
Gravity.
force.
Okay?
Yeah.
You wanted to say it. Is this right?
Yeah, gravitational force.
Okay. So the perfusion of the basal lung regions, okay, will be higher than that of the apical lung regions because due to the length of blood column. The length of blood column, it's higher for the basal lung regions, and for the apical lung regions, it will be shorter. Okay, so by the effect of gravity, the perfusion of the basal lung regions will be higher than the apical lung regions. Do you think, Dr. Sai and Batul, that this is something that we want to be? Is this okay for us?
Uh, because the gas exchange is also more at the base, so if
The ventilation is more at the base of the
more,
lung.
yeah,
Okay,
so
so there will be a better gas exchange.
better.
Okay, So we can say that there will be better ventilation perfusion matching. This is the medical term that we can use in this situation. Okay, so
Okay.
the effect of height, actually, you can imagine the effect of being upright, and for the lung to be above, or the apical lung regions to be above the level of the heart. You can say that that will be a minimal effect. Okay. For example, we have our brains, which is higher than the lung, and it is well perfused. Why do you say that the gravity will affect the lung and so on? What do you think, Dr. Sai or Dr. Batul? Is the When we talk about the brain, do you think we will talk about gravity and blood column and so on? Why we talk about the lung, although, or the brain is at a higher level? Yeah, if the environment around you, Dr. Sai and Dr. Batul, is quiet, please open your mics and talk to me.
Also depend on the gravity.
Sorry, Batul, can you repeat what you said?
Also depend on the gravity.
It depends on the gravity. So we will consider the gravity when we talk about the cerebral perfusion as well. That's what you want to say, Batul? Sai, what do you think?
We don't take gravity as a factor when we talk about cerebral perfusion. I don't think.
You don't think. So why do you think I consider the gravity when I'm talking about the perfusion of the lung?
Mm,
It's a very easy, to the extent that you don't direct your thinking towards the right answer. Do you think that the lung and the brain, are they perfused by the same circulation?
no.
Can you complete your answer, Sai?
Mm, There's the pulmonary circulation is the lung is perfused by pulmonary circulation, which is different. There's two mediums involved.
So what do you think is the difference between the pulmonary circulation and the systemic circulation? Is there a difference?
The pressure difference, the in
The pressure
pulmonary
difference
circulation,
is very
pulmonary,
large. There is a very large pressure difference.
yeah.
So at a change of 30 centimeters of water, okay, which is blood as its height, it is a big change in a low pressure and low resistant pulmonary circulation. Okay? Did you
Yes.
get what I want to tell you about this topic?
Yes.
Okay? So you can imagine if we change the position of this patient from the upright position to the supine position, what do you think the change will happen to perfusion?
Decrease in perfusion.
Decrease in perfusion of which regions?
The
Where the blood
base.
will go preferentially, Dr. Sai?
Oh,
You said in your answer it is a gravitational effect.
yes.
Okay? So what do you think the distribution of blood will be?
Mm,
You can say anything, Sai. We are not in an exam. You can say anything. We are in the supine position. So by the effect of gravity, the perfusion will be higher, not at the base of the lung in comparison to the apex. It will be for the posterior lung regions
Yes.
in comparison to the anterior lung regions. If this is the lung, so the posterior lung regions will be perfused better than the anterior lung regions. Okay? And the
Yes.
difference between the base and the apex will will decrease. Is this
Mhm.
right?
Yes.
But will be maintained. Okay, so the difference will decrease, but still the basal lung region will be perfused better than the apical lung regions. Okay? But in general, the perfusion of the posterior lung regions will be better than the anterior lung regions. This is a very important piece of information related to a very important clinical topic, which is acute respiratory distress syndrome. One of the important non-ventilatory management of ARDS is, do you know?
No.
Non-ventilatory management of ARDS.
No, sir. I don't.
Batul, do you know any of the non-ventilatory managements of ARDS?
Position.
Position. Which position? What we do in ARDS? Did you hear about the prone ventilation?
Yes.
Did you hear about prone ventilation? Sai.
Yes.
Okay.
Oh,
Why do we do this? We now this patient, the anterior lung regions, which are well ventilated, okay, because the posterior lung regions are congested, okay. So when I put the patient in the prone position, the anterior lung regions, which are well ventilated, will now better perfused by the gravitational effect. So it will improve ventilation perfusion matching and improve oxygenation.
Mhm.
Did you understand?
Yes.
yes.
Okay. So uh, we can return back to the curve. You can see here that perfusion decreases from the base of the lung towards the apex. Okay. A very important piece of information which is asked frequently in multiple true and false questions and in oral exams, they say or asking you about the perfusion and the ventilation both decreases towards the apex of the lung, but the degree of decrease in perfusion is higher than that for ventilation. Okay, so the perfusion decreases more towards the apex of the lung in comparison to ventilation. Okay, okay. Now you know when the function of the lung, the one of the main functions of the lung is gas exchange. Okay. So for gas exchange to be optimal, there must be some sort of matching between ventilation and perfusion. In optimal conditions, VQ must be, what do you think, Sai? VQ in optimal conditions must be equals equals 1, more than 1, or less than 1? The question is for Batul as well.
Doctor, can you repeat the
For
part?
gas exchange side to be optimal, the VQ ratio, the ventilation perfusion ratio, should be 1, more than 1, or less than 1?
Less than.
Batul,
I think less than. Less than 1.
less
Less
than 1.
than 1.
Less than 1. Sai, do you think the same?
Yes.
So you say that ventilation should be less than perfusion for gas exchange to be optimal. Is this logic answer? Okay. For gas exchange to be optimal, there must be matching between ventilation and perfusion. So optimally, the VQ ratio should be 1 optimally. Okay, should be 1. So ventilation should equal perfusion. Okay, but this is not the case physiologically. Let's now see this curve. At this point, if we extended a line here, we can see that at this point perfusion equals ventilation, so the VQ equals 1. If we take a line or draw a line at this point and another one at this point, okay, here this is ventilation and this is perfusion. So ventilation is higher than perfusion. So VQ ratio will be higher or lower than 1? It's very easy.
Less than 1.
Less than 1. Why, Batul? Ventilation is higher than perfusion.
More than 1.
More than 1. Okay? So as you see here, this is more than 1. Okay? The other line, this is ventilation and this is perfusion. It's evident that ventilation is lower than perfusion. So VQ ratio will be less than 1, as you see here, okay? So for ventilation, for gas exchange to be optimal, the VQ ratio should be or around 1. If the VQ is more than 1 or less than 1, this called VQ mismatch. Okay? So more than 1 is not good. Do you understand this, Sai and Batul?
Yes.
Okay, so any deviation from 1 is called mismatch. Okay? When ventilation is higher than perfusion, this means that some of the alveoli which are ventilated, not perfused. So this is called dead space. And this occurs at the apex of the lung. At the base of the lung, ventilation is less than perfusion. So some of the blood does not perfuse any alveoli. So this blood passes from the left side to the right side without taking part of gas exchange, and this is called shunting. Okay? So physiologically, VQ ratio is around 0.6, 0.7. The examiner will ask you why it is not 1, because there is dead space, physiologic at the apex of the lung and the airways that we'll talk about in the next topic. And at the base of the lung, there is some sort of shunting. Okay, so this makes the VQ ratio less than 1, around 0.6 to 0.7. Okay, is this clear, Dr. Sai and Batul?
Yes.
Okay, so let's now talk about the West zones. What's West zones? West zones, it divides the lung into 3 zones by 2 imaginary lines. Okay, the 2 imaginary lines divides the lung into 3 zones, 1, 2, 3. West zone 1, 2, and 3. Okay, and we compare in each zone between the alveolar pressure, the arterial pressure, and the venous pressure. Okay, so this is the alveolar pressure, this is the arterial pressure, and this is the venous pressure. Okay, so this is the lung. These are the West zones, 1, 2, 3. Okay, we said that in the apical lung region at rest, the alveoli are distended. Why it is distended? Because there is a high negative pressure intrapleurally around it. Okay, so in the with zone 1, the alveolar pressure is high. Okay, and it is higher than the pulmonary arterial pressure, which is normally higher than the pulmonary venous pressure. Okay, what happens if the alveolar pressure is higher than both the arterial and venous pressure? The distended alveolus compresses the adjacent capillaries, either the arterial or the venous. So these alveoli will be ventilated but not perfused. And we said this is called the alveoli which are ventilated but not perfused are called
Dead
called
space.
dead space, alveolar dead space. Okay, if we moved down, okay, the arterial pressure will increase and the venous pressure will increase as well. Okay, but the arterial pressure will be higher than the alveolar, but still the alveolar pressure is higher than the venous pressure. Okay, so in anywhere in the body, the passage of blood from the arterial side to the venous side depends on the pressure difference between artery and vein. But here in the second lung zone, because the alveolar pressure is higher than the venous pressure, so it compresses the vein. So for the blood to pass from the artery to the vein, the arterial pressure should overcome this external pressure, which is the alveolar pressure. So the blood flow from the artery to the vein is dependent on the pressure difference between the arterial pressure and the alveolar pressure, not the venous pressure. Okay?
Okay.
This is sometimes they called this area water shedding areas. And this area is the best for gas exchange. Okay? If we moved more downwards, will the arterial pressure and the venous pressure will increase more and more. So the arterial pressure will be higher than the venous pressure, which is now became higher than the alveolar pressure. So now the artery and the vein are very distended, the pressure is high and higher than the alveolar pressure. So the distended vessels compresses the alveoli. So the alveoli will not be ventilated and the blood will pass from artery to vein without taking part of gas exchange. This is called
Shanti.
shunting.
Shunt.
Excellent. Okay. Last piece of information I want to tell you about that zone 1 is physiologically absent. Okay. Zone 1 is physiologically absent. Okay. Why? Because the pulmonary arterial pressure is high enough to be higher than the alveolar pressure under normal conditions. Okay. So when does zone 1 appear? In two conditions. Either the the alveolar pressure increased or the pulmonary arterial pressure decreased. What increases alveolar pressure? What increases the alveolar pressure?
And there's positive pressure ventilation.
Excellent. Positive pressure ventilation. And what decreases the pulmonary arterial pressure? It's very easy. Hypotension.
Okay.
Okay, hypotension,
Yes.
either due to vasodilatation, hypovolemia, low cardiac output, whatever. Okay,
Yeah.
so
Yes.
when this happens, zone 1 appears and the patient will start to desaturate. This happens when you, sometimes in some cases, when you start to induce anesthesia in some patients, you can see on the monitor that the patient starts to desaturate. The saturation is around 96, 95. Okay, if you measure the arterial pressure at this point, you can find that the patient is hypotensive. In some procedures which needs hypotensive anesthesia, some patients starts to desaturate due to severe hypotension. So zone 1 appears and leads to appearance of the alveolar dead space, which leads to arterial desaturation and so on. Okay, so this is a clinical point related to West zones. The last thing that related to the pulmonary artery floating catheter or Swan-Ganz catheter, where do you think the best point or the best region or the best zone we have to place the pulmonary artery floating catheter in? Zone 1, 2, or 3?
Oh, I'm not sure. 2.
You are not sure, but 2. Okay. What do you think, Batul? Okay,
But
so the best zone will be zone 3. Why? Because this is the only zone where there is direct communication between the pulmonary artery and the pulmonary vein. So I can, when I wedge the pulmonary artery catheter, I can measure the pressure in pulmonary veins which reflects the left atrial pressure and the left ventricular end diastolic pressure. Did you get the point?
Yes.
Okay, I think we can stop here. If you have any questions, I'm listening. Oh my, oh, tell me. Do you have any questions?
No, sir. Just
Okay, thank you. And meet you inshallah next Wednesday inshallah. Assalamu
thank you.
alaikum. Thank you.